Hi, my name is Micah Long, and I'm a critical care anesthesiologist who does ECMO in some of our intensive care units. As we rolled out ECMO and started really heavily using ECMO at my hospital, I realized very quickly that ECMO sounds and looks really challenging and is hard to teach quickly, but ECMO isn't as hard as we make it sometimes. And my goal of these talks was to create a very straightforward way that I could communicate what's happening with ECMO and deal with complications of ECMO quickly and effectively at the bedside as our ECMO utilization increased. To do this in a simple way, I like to think very simply. When I think about a patient on ECMO, I really want to know what's going on with the blood going round and round their body. To do that, I draw a heart, and then I draw the vena cava and blood flow to the lungs. From the lungs, we go out the body in a VV ECMO patient. This blood is blue because the lungs are not working. And I go out the LV, up the aorta, and down to the femoral artery. Once I have this drawn in, I want to know where the ECMO is pulling blood from. Frequently from the femoral vein. Of course, the cannulas go higher, but this is simple for drawing. Then I write what the ECMO is doing, pump and oxygenating, pumping the blood around and then oxygenating it, clearing CO2. And then I draw good red blood from the ECMO circuit and where it goes to. In this circumstance, I've drawn femoral draw to ECMO, and then ECMO to the IJ, or a FEM-IJ VV ECMO cannulation setup. Once I know the good red ECMO blood is going here, I can draw all of the blood past it as red, knowing, of course, that ECMO is not cardiac bypass, and so this red blood will be mixed with some degree of venous admixture, which sometimes clinically matters, and we'll go through some of those cases in the upcoming slides. The first patient I had on ECMO was a patient that had blastomyces ARDS. We put them on femoral to internal jugular ECMO support, and when I was in the room doing the cannulation, everything seemed to go great. We cannulated them, they had big, nice vessels, they were not hypovolemic or bleeding, and we started at a typical RPM setup just over 4,000 and got a flow of about 5 liters per minute. We turned the sweep to 5 liters per minute to match that, and the FiO2 of that sweep was 100%. Pretty typical initial settings. Unfortunately, the patient didn't cooperate. They were still not looking right. Their arterial saturation was 83-85%. We did a blood gas as we sat there troubleshooting this, and it had ongoing acidosis. We took a look at our cannulas and noticed the problem. The cannulas were both exactly the same bright red color. Our ECMO specialist was looking at the ECMO data from the monitors on the ECMO device and showed that the premembrane saturation was high. It was 93-94%. And we realized what was happening was recirculation. Recirculation on ECMO occurs sometimes, and it's the problem of my simple anatomic drawing that shows blood being pulled from the femoral vein to the ECMO device, when really the cannulas go much higher. Cannulas on ECMO going from the femoral vein go all the way up towards that right atria and sometimes at the right atria. And similarly, our cannula from the right IJ delivering nice red blood sometimes goes into or just below the right atria, and those can overlap. We see this on chest x-rays sometimes, which I've shown here, but the main point is your venous ECMO line should look dark blue. If it looks exactly the same as your red good ECMO line, there's a problem going on. This is called recirculation, where the blood literally goes around and around in a circuit, and the circuit works great, but it's not going to the patient where it matters. Now, this idea of always looking at your cannulas was highlighted to me several years ago when I took over the care of a complex patient who was on VV ECMO. I was called to the room soon after I took on the service. I hadn't examined everybody yet, and I was told there was a huge mucus plug and the patient was desaturating. I walked in, and the team handed me a bronchoscope and said, "You got to do a bronch. They have a mucus plug." I did a bronch. There's a little mucus. But as in the midst of this bronch, I thought, wait a second. Why am I doing a bronch on a patient on ECMO? The ECMO should handle this saturation. And I undid the gown and saw quickly that the cannulas were both dark blue venous blood. I knew then immediately that there was a problem with the ECMO circuit. Since it was not alarming low flow or a high pressure gradient over the oxygenator, we were worried about the oxygen supply. As it turns out, the team had transported the patient somewhere, hooked them up to a cylinder of oxygen, run out of the oxygen, and forgotten to plug them back into the wall. Things didn't go well as they got hypoxic, but the moment we plugged that oxygen in, things got better and everything went well for the patient. Always look at your cannulas. The second patient I took care of on ECMO was a younger patient that we use a single cannula ECMO circuit for. Single cannulas came out and sounded really phenomenal. They're single cannulas because there's just one big ECMO cannula. It goes in the neck, and it has the ability to draw blood from both the IVC and the SVC, and then it delivers blood into the right atria. They're relatively easy to place. Since it's a single cannula, it just goes into the neck. You, of course, have to be very mindful of where the blood is being delivered to, so it enters into that right atria pathway. But they tend to be very position sensitive, and while they were billed as these wonderful things enabling patients to walk and move around without a femoral cannula, it turns out that that positional change sometimes made this a challenge. They sometimes recirculate, although that hasn't been a problem for me. This is one example of a brand name one called the Crescent cannula, and you can see it has a port it draws blood from in the SVC, just a single fenestration here, a multi-port fenestrated lumen down below, and then each one of these lumens is smaller than a Fem-IJ setup, but it delivers blood into the right atria. This is shown in anatomically correct format here with this fenestrated IVC draw, single draw at the SVC, and delivery of blood into the right atria. The patient I took care of with this single-stage cannula had suffered from a blast injury and was very hypoxic. They were also fairly young and had a very strong heart. We put this single lumen cannula in expecting that we could optimize them for recovery and rehabilitation by ambulating, and what we found right away was that we got about 4 liters flow at maximum. We put the sweep at 4, put the FiO2 to 100%, did not have any circuit problems, but had persistent desaturation on the arterial side of the ECMO of the patient. Now, patients particularly with lower flows, are prone to this problem of persistent hypoxia despite ECMO support. And this can occur due to flow mismatch or low SVO2. And the core concept here is actually quite simple. It's to remember that ECMO is not bypass, and the arterial blood, what is on the arterial aortic side, is going to be a mix of good red ECMO blood and whatever native venous admixture bypasses the ECMO circuit. And so when you think through the problem, you want to make sure that what red blood is going in is enough blood, that you have enough flow, that you have enough hemoglobin to capture the oxygen you're delivering, and you want to get a rough idea of what's happening on the venous side of things. It could be that your SVO2 is very, very, very low in the case of either a high metabolism of oxygen in things like infection, with a seizure, horrible inflammatory states, or things like shivering, agitation, or pain. Or it could be that your DO2 is lower than you anticipated and that the heart is failing and that the extraction ratio of oxygen is high, both, of course, resulting in a low SvO2. The other problem is the opposite of a low cardiac output. It's a high cardiac output. ECMO will pull some amount of flow through, limited by your cannula sizes. If you're a young, healthy, vigorous person, you may be able to mount a 10, 12, or even higher cardiac output in liters per minute. If your ECMO circuit is maxed out at 3 or 4 liters per minute, well, you have 3 or 4 liters of good blood, and you have 6, 7, or 8 liters of hypoxic blood bypassing your ECMO circuit and going through lungs that don't work. Knowing that and thinking through it from the drawing dictates what you do. If the problem is with the ECMO blood, you can, of course, change your drainage cannulas and turn up your RPM to optimize flow, but you may consider a higher hemoglobin transfusion threshold. ECMO is not a standard hemoglobin of 7 threshold. We, of course, want to be conservative with our blood utilization, but if your ECMO DO2 is poor and it's related to anemia and a non-functioning lung, you need to ensure that they have enough DO2 to maintain need and demand throughout their body. If the problem is a high metabolism of oxygen, that might be the first sign of a second infection. We control the temperature of our patients on ECMO, so you don't have fever as a highlight of an infection. You need to have a high suspicion of infection in these patients who are sick with an activated inflammatory cascade and huge cannulas going in and out of their body. We sometimes paralyze for shivering or simply to decrease their metabolic rate. And of course, you can make sure they're not febrile, that they're comfortable, and the like. You want to confirm that their cardiac output is adequate. You can, of course, improve their SvO2 by hemoglobin transfusions. You can improve your DO2 of ECMO with transfusions. But you want to make sure that your heart is functioning enough to push that blood around. Every once in a great while, if you think this flow mismatch is just related to hyperinflammatory high cardiac output state, you may consider decreasing the cardiac output with something like esmol to decrease the native venous flow, or using the lungs. I say we don't do this very often because the whole point of ECMO is to not use the lungs. You don't want to add in hyperoxia injury or vent-induced lung injury, and cardiac output doesn't necessarily mean your DO2 is low. The SaO2 does not equal your DO2. You need to make sure you do this math out when you have persistent hypoxia. It may be that your cardiac output and SAT of 85% is just fine for your DO2, and 85% may be adequate. It may be, if your cardiac output's low, that 85% is not adequate. But you need to figure this out. The Red Book offers some guidance in terms of how to do the math and calculate your DO2 to VO2 ratio. But in terms of thinking simple, you really need to know that your SVO2 is less negative than 25% below your SaO2. In other words, if your SVO2 is impeccably low, you've got a very real problem on your hands, and you probably shouldn't decrease your native venous output in that state. There's an interesting case I took care of that highlights the last type of cannulation strategy for VV ECMO I'll talk about. I was called emergently to a cardiology ICU, not a unit I normally staff, one morning. A patient had arrived after a STEMI. The cardiologist had saved their life with a stent, but their LV was stunned. That low cardiac output necessitated an LVAD being placed in the cath lab. And with that LVAD, their heart function was there. They had cardiac output, but they were horribly hypoxic due to pulmonary edema complicating their STEMI. They were put on VV ECMO to help this. It was a single cannula in their neck, and they were getting pretty typical settings on the VV ECMO, but the LVAD was alarming for suction. Now, those of you that don't do LVADs much, I'll tell you that LVADs will suction if there's not much blood in the area of the heart they're in. So if there's not much blood there in the LV, it will suck in towards the septum and it will alarm. The main concern you have with suction is that the patient's either bleeding out or hypovolemic, and so you want to give fluids. In the case of an ECMO patient, the team was really worried that the ECMO was pulling too much blood away from that VAD and causing the suction. And so they were turning down the flows on ECMO in order to give enough preload to that VAD, and things got worse. It turns out that the patient had a different type of single-stage cannula. They had a right atria to pulmonary artery configuration of an ECMO circuit. These are single-stage cannulas that are akin to a pulmonary artery catheter or a swan. They pull blood through from the RA that goes to the ECMO circuit, and they deliver blood past a competent pulmonary valve into the PA. They're okay for mobilization. They're okay for flows. They're, of course, slightly smaller cannulas than a FEM-IJ, but they can be hard to place, and they're certainly hard to wean. And they're hard to wean because, as you notice from this drawing, you're pulling blood from the right atria and delivering it to the pulmonary artery, bypassing this RV. These are RVADs. Whether or not you're using them like an RVAD is different than how they function in real life, which is as an RVAD. So while it is VV ECMO, it's venous to venous, it's still on the right side of the heart or the pre-lung side of the heart, these absolutely are an RVAD. That LVAD suction event was happening because as they turned down the flow, the RV was not pumping enough blood. And so the blood was, of course, going past the RA into the RV because we were turning down that ECMO. But the RV had failed too. And so the blood was sitting there in the RV, not going across to the left heart. And so the LV was empty and causing a VAD suction event. Don't forget these unique single-stage cannulas are RVADs. In summary, ECMO is straightforward. It consists of a pump and an oxygenator. The pump flow is preload and afterload sensitive. If the flow changes relative to your RPM, be very mindful of this very simple differential and work it out. Always look at your cannulas. You can identify problems with the ECMO circuit and recirculation quite quickly with nothing advanced. It's simply part of your physical examination. Persistent desaturation on ECMO is a major problem that if you do ECMO for even a short window of time, you will see. The problem is either a problem of good red ECMO blood, there's not enough of it, or there's not enough hemoglobin to bind that oxygen you're delivering, or there's too much venous blood. It can be that venous blood has a horrifically low saturation in the case of high metabolic drive for oxygen or low cardiac output. Or it could be that there's a lot of venous blood because your cardiac output's very, very high. Remember, your DO2 does not necessarily equal your SAT. Make sure you check your cardiac output before you do anything about this and work it through. Remember, finally, that some single-stage cannulas are RVADs in disguise. I hope that simple mechanical model is helpful for you to understand common cannulation problems for the patient on VV ECMO. Now, if you're a nerd like me, you'll want to work through some of these persistent hypoxia problems so you know what to do. Persistent hypoxia, again, is a problem with either not enough good red blood, not enough oxygen in that good red blood because of anemia, or a problem on the venous side. And that problem can be that your SVO2 is really, really low due to high metabolism of oxygen or low delivery of oxygen. Or it could be that you just have a lot of it because you have a lot of cardiac output. Solving that problem runs you through the typical check the red side, make sure your flow is optimized, make sure you have the right sized drainage cannulas in, and that your RPM is turned up safely enough. You want to transfuse sometimes on ECMO for these reasons. You want to work out why the patient has a high metabolism of oxygen and ensure they have a good delivery of oxygen, and correct those things accordingly. We don't frequently decrease cardiac output or use the lungs, and it's important to remember that we simply sometimes do nothing. A SAT of 80 or 85% may well be enough to ensure adequate DO2. You want to make sure your SVO2 is not lower than 25% below your SaO2, and when you have achieved that or are near that, you want to do some real nerdy math. Now, the nerdy math that's hard to remember and definitely needs a quick reference somewhere stored, maybe on your smart device, is a variant on the Fick equation. Now, going through all the assumptions and problems of the Fick equation is a little beyond what I want to do today. The goal of today is to give you a quick and dirty way to make sure that the amount of oxygen you're giving or that's being delivered to your patient from their own heart and ECMO is enough. To do that, we need to figure out the DO2, the delivery of oxygen throughout the body. We know the DO2 equals how much oxygen is there times the cardiac output. And we know the math for how much oxygen is there. It's the hemoglobin times the SAT times 1.34 plus what's dissolved, which is pretty minimal, so we're going to leave it out here. We, from that, can determine the cardiac output with a whole host of other assumptions that are reviewed in the ELSO textbook and older physiology textbooks. But remembering that the SAT is the core contributor to the amount of oxygen in an area, and your hemoglobin not changing throughout the sites you would check it, the venous, arterial, ECMO side, your hemoglobin doesn't change. You can use this bottom left equation, which is easy enough to remember, to make the rest of the math simple and easy to recall. Cardiac output equals the blood flow you get on ECMO times the SAT gradient, ECMO to venous minus venous, divided by the SAT gradient, arterial minus venous. Venous on both sides. Fairly easy to remember. The ECMO SAT's always going to be 100, so 100 minus your SVO2 divided by your arterial SAT minus your SVO2. That gives you your cardiac output. We fill that into our top equation to get our DO2 using the total amount of arterial supply here. From there, we need to know if that amount of oxygen delivery is enough for your patient. From here, we can make some more assumptions. In general, your VO2, the oxygen you metabolize per minute in an ICU environment, is about 3 mils per kg per minute. What your goal is to have enough headspace over your DO2 or over your VO2, enough headspace of DO2 to prevent ischemia. In other words, you want extra DO2 relative to your VO2. You want more oxygen going round and round the body than the metabolism of oxygen. And the reason you want this is not only for safety and a little protection if the DO2 drops, but also because different areas of your body use different amounts of oxygen. Your brain and heart, of course, use a fair amount of oxygen, and you want to make sure you're not just protecting the average of the body, but you're protecting those core organs that might be sensitive. So you want to do that math and then determine that your DO2 to VO2 ratio is over 3. If it's not, you need to optimize your DO2, either by transfusing, turning up the ECMO flow, or adding inotropy in the case of a low cardiac output. Here's some examples with math. And I'll tell you, I've stolen these from the ELSO textbook, but know that the ELSO textbook has a fair number of algebraic errors in these. These have been reviewed and vetted by several of my colleagues, and I believe they're correct. But they are the stolen case examples from the ELSO textbook, which I've referenced there in the right. I've included the slide prior as a reference on the right. Patient number 1. No lung function, 70 kilo adult with a SAT of 88% and an SVO2 of 64%, flowing 4 liters on ECMO with a hemoglobin over 10. We see that the amount of oxygen in the arteries is 12.4 mils per deciliter. We then can determine the cardiac output, or the DO2, which is 60 deciliters per minute. We know the DO2 needs to be more than threefold the VO2, and if they're 70 kilos, 3 times 70 equals an estimated VO2 of 210 mils per minute, and therefore our ratio is perfectly safe at 3.54, and we're in a good place. If that patient's cardiac output increases, but the ECMO doesn't change, they're going to have more of that venous admixture bypassing the ECMO circuit, and their SAT is going to go down. For this example, I put that their SAT went down to 84%, and their SVO2 is 64, hemoglobin's unchanged. Their VO2, using the exact same math as before, is now 210 mils per minute. Now our cardiac output's higher. I've filled in the values there, but it's 72 deciliters per minute. We can multiply that out and have a DO2 value of 850 mils per minute, which is in green here, higher than it was before, even with that lower saturation. Therefore, you're perfectly safe to let the patient sit with a SAT of 84%. However, what if they start to bleed? Now we have a hemoglobin drop to 8. As we've mentioned before, ECMO can only deliver oxygen to hemoglobin, which binds the oxygen, of course. And so as you drop your hemoglobin, your ECMO delivery of oxygen is going to go down. Similarly, your delivery of oxygen to the body is going to go down. So the cCO2, the amount of dissolved oxygen, is going to go down. The DO2 will rely on a higher cardiac output. We can do the cardiac output math and see that our DO2 to VO2 ratio is now under 3. And while things might not be bad yet, the problem of DO2 to VO2 being too low is that SVO2 is going to drop more and more, and things will get worse over time. Problem here is that as you get more anemic, you're decreasing how much oxygen is delivered by the ECMO. And so it's useful to talk through how we calculate how much ECMO oxygen delivery occurs. I've drawn in some math here. The short story is what you want to do is calculate out the amount of venous oxygen goes to ECMO, and then you subtract that from the amount of arterial oxygen on the arterial side of ECMO. So that oxygen dissolved on the arterial side minus the oxygen dissolved on the venous side gives you a delta oxygen. You multiply that by the amount of blood flow through ECMO, and that gives you your DO2 of ECMO. If your DO2 on ECMO is not high and it approaches the VO2 of the patient, that's a very dangerous situation, and things may not meet demands and could get worse quite quickly. You want to make an adjustment and a change, either transfusing, going up on flow, or adding cannulas very shortly before things go south. And so I use this as a highlight that a non-specific hemoglobin threshold of 7, as we apply to many critically ill patients, may be horrible for your ECMO patient. I hope this is very helpful to give you a guide of going through the detailed math of ECMO to know when it's better to turn the RPM up or to transfuse, overlying a very basic introduction to the anatomy of ECMO. Thank you for your time, and I hope you have a good day and your next ECMO patient makes it and thrives.